So welcome everybody this morning to our town hall. It is my pleasure to introduce Morgan Philbin, who's an assistant professor in the Department of Sociomedical Sciences at Columbia University at the Mailman School of Public Health. She is a social behavior scientist who mixed method research examines social structure drivers of HIV and substance use outcomes with a focus on racial, ethnic, and sexual and gender minority health. Her primary research project is a NIDA-funded K01 that explored how state-level policies impact substance use and sexual health outcomes among Black, Latinx, sexual and gender minority youth. And she was recently awarded an R34 from the NIMH to develop a patient decision aid to help individuals understand with their providers between choosing between oral and long-acting versions of antiretroviral therapy. Dr. Philbin's conducted research on substance use and HIV in the United States, Mexico, and China, and recently awarded an outstanding award, the 2021 NIH Office of Disease Prevention Early Stage Investigator Lecture Award. So her talk today is interrogating the promise of biomedical HIV technologies, health disparities, and the rollout of long-acting injectable ART and PrEP. So it is my pleasure to introduce a colleague and friend here, Morgan. Take it away.
Awesome. Thank you so much. So let me start this, and then if someone could just tell me once you can see my screen so I know that I'm that I've done it correctly. That would be great. We all good?
Yeah, we're good.
Perfect. So thank you so much, John, for the introduction. It's so nice to see you over Zoom. Not quite the same. John and I got to hang out in LA in June, which was awesome. But I'll take what I can get. And I also want to say thank you to Rochelle and Mallory for helping facilitate this talk. I'm really excited to present my work here, particularly given how many of you that I've gotten to know over the years and how many of you whose work has informed my own. And briefly, as John mentioned, while this talk today is focused on long-acting injectable ART and PrEP and uses qualitative data, I have another stream of work that takes a more quantitative approach to examine how state policies affect HIV and substance use, including how those differentially affect minoritized youth and young adults. So I'm not going to explicitly talk about my policy research today, but a lot of those same themes around inequities and differential impacts that arise in that work are also relevant here. There we go. So I'm going to begin the presentation with a brief overview to discuss how the rollout of long-acting injectable ART and PrEP can be examined through a lens of health equity and health justice. And I'll then provide a short background on the state of the science of long-acting injectable ART and PrEP to make sure we're all on the same page. And then I'll discuss the study methods for the the data I'm going to be focusing on today. And then I'll provide some case studies to illustrate potential barriers and facilitators to scale up that came up in my work. And I know that many of you are also conducting research on long-acting formulations of ART and PrEP. And so my goal today is really to use this presentation as a way to share some of the themes that I'm seeing in my work in order to help identify potential synergies and to start a dialogue. And so during the Q&A, I'd really love to hear more about whether what I presented resonates with the work that you're doing and to learn more about what you all are researching. And I'd also love to identify potential avenues for collaboration. So if anything you see sparks your interest, definitely please reach out. Also, as John and I were alluding to in the beginning, for those of you who joined early, I'm actually in the middle of packing up and I'm moving out to California in October, into San Francisco actually. So I'll be in the area if any of you want to meet. What are we allowed to do at a park outside in a cafe? Fingers crossed by October, November it gets a little bit better. So today my goal is to make the case that the scale up of long-acting injectable modalities is really an ideal time to recenter the discussion around HIV treatment and care access through a lens of health equity and health justice. And in doing so, we can tailor our approach to ensure that all individuals who need HIV treatment and prevention can access it both domestically and globally and in the formulation that they want and in ways that most benefit them. So as a result of many of the research contributions, including from those of you, if you want to say in the Zoom room, the field of HIV/AIDS has produced an incredible amount of biobehavioral research and has made important advances in HIV treatment and prevention. And long-acting ART and PrEP really do hold incredible promise for slowing the course of the HIV epidemic and helping us achieve our goals of increasing equitable access. But I do want to start with the but. They're not a panacea. HIV fatigue is very real. The media is paying less attention and funding streams have shifted or become less robust. And at the same time, people in the US and across the world are still getting sick and dying at alarming rates, particularly within marginalized populations. And as we've seen historically, new biomedical technologies often benefit very specific segments of the population and can actually end up reifying disparities that affect access to HIV treatment and prevention. So again, long-acting injectable modalities have potential, but they alone are insufficient to end the epidemic. They might be a better option for some, and they must also be an option for all. So much like we saw with COVID, the same populations that were most at risk are also the least likely to have access to treatment and to the vaccine. So this move toward increasingly technological options is an ideal time to recenter communities and to ensure their needs are met. So the fundamental causes of health inequalities theories from Morgan Philbin, as many of you know, shows how novel health technologies can create disparities in the distribution of healthcare that did not previously exist. And this is because certain people gain access to these technologies based on factors like education, race and gender, knowledge, power, and social capital. And this is most salient with health outcomes that are preventable, such as HIV. So we can produce new biomedical technologies, but if nothing shifts on a structural level, then these technologies will only benefit individuals who would most likely remain adherent to ART or PrEP, regardless of the formulation. So we must ensure that we apply this framing and what we already know about disparities in the distribution of oral ART and PrEP to make sure we help facilitate equitable access to long-acting injectable formulations of these drugs. So I want to touch briefly on these transversal themes as they affect access to medical services for many different diseases, including HIV. So one are multi-level barriers, which we talk about all the time with the socio-ecological framework. Another is public health messaging. One is around coercion and making sure that whoever is most impacted can engage and share decision-making, whether it's around condom use, PrEP, long-acting formulations, and then also thinking about the need to increase confidence in science. And so in this presentation, I'll really argue that these themes will only become increasingly relevant as we expand long-acting versions of ART and PrEP, particularly given patterns we've seen when the same expansion occurred for things like substance use treatment and mental health treatment. And so when it went from oral to long-acting injectable versions of medications. And I also want to note that these themes are particularly relevant when the affected individuals are marginalized or face power differentials that challenge their ability to advocate for their own needs. So I'm going to present 3 hypothetical case studies later in this talk to illustrate potential drivers and barriers to equitable scale-up. And I want you to keep these 4 themes in mind as I do so. Also, while today I'm talking about HIV, I just want to take a moment to highlight that these themes are relevant to many other diseases. I know we talk about COVID all the time, but I just want to highlight this because I think there are a number of things that are particularly applicable for the way that we think about HIV testing, linkage, and care engagement. So I'm not going to belabor this point. I know that many of you have already thought extensively about this, but I do want to highlight a few specific things so they're in the front of your mind. So we've talked a lot about health disparities in COVID and why they have played out. And so I want to think about the vaccine coverage for COVID and what that might mean, particularly since it was a new biomedical technology, much like long-acting injectable versions of ART and PrEP. And the way the rollout of COVID vaccines was conducted can provide some important things for us to consider for long-acting injectable versions of HIV treatment to maximize the likelihood that we will reach people in ways that maximize equity and where they feel safe telling us what they want and what versions will work best for them. Second, for many people, the COVID vaccine may be the most recent injection they've received, or at least the last one they thought more deeply about. So maybe some have gotten the flu vaccine, but that has become more routinized over the years. So we need to think about what this means for their willingness to use an injectable formulation of another drug. What first comes to mind are some of the vaccine side effects, most notably with Johnson & Johnson and women, and what this might mean for how people engage with long-acting injectables. Also, similar to HIV, our COVID response included lots of public health messaging with varied success. And this highlights the importance of message framing around new technologies and how we need to highlight the full range of options from long-acting to oral meds or even nothing at all, and framing it around things like empowerment and autonomy and protecting others versus paternalism and coerciveness, which public health has done a little bit in terms of fear-based campaigns, which I know many of you have worked on. Third, COVID has changed the way that people with HIV and at risk for HIV engage with medical care and services. So while in the US, some people were able to switch to telehealth under COVID, that is not the case everywhere in the world. Also, oral medications can be distributed through local pharmacies or mailed directly to people, which during COVID is important for protection, but long-acting injectable ART, for example, would require them to come into the clinic monthly. And also research suggests that COVID has also shifted patterns of how and with whom people are having sex, which may have implications for who needs PrEP. Lastly, COVID, among other political things that have gone on in the last 4 years, have just truly wreaked havoc on the public's confidence in science and in institutions more broadly, which I really want us to keep in mind because it has implications for how people engage, not just with the technology itself, but with the institutions that are rolling it out. So while biomedical technologies are promising, they do face very entrenched barriers that advancements in medical technologies alone cannot fix. So, racism, sexism, transphobia, lack of insurance, and an underfunded healthcare system. So this highlights the dire need to address structural inequalities while simultaneously developing new treatment and prevention options. And then these options must be made available in ways that benefit people who face challenges adhering to daily pills. So providing additional tools to people who are already adherent is important, but it will not change the course of the epidemic. So I'm just briefly going to touch on oral PrEP and use it as a way to build off of some of the challenges that we'll face with long-acting injectables. So as you know, PrEP was first approved in 2012, and yet we're still very far from where we need to be to substantially lower HIV transmission. So the PrEP to need ratio, which is the ratio of the number of people using PrEP to the number of individuals newly diagnosed with HIV infection, has been used as a metric for measuring population level coverage of PrEP. And I just want to highlight the geographic disparities in this. So if you look at the South, right, where things are red and orange, where the ratios are lower, it suggests that there is less PrEP coverage in comparison to the Northwest. So this is not surprising given that most Southern states have not expanded the Affordable Care Act, and they also tend to have higher levels of structural racism, sexism, and homophobia. And this is just to remind everybody, as we know, like this rollout is not happening in a vacuum. We cannot assume that what is going to happen in a clinic in San Francisco or New York is going to be the same as Georgia. So in 2018, about a little over 1 million people had indications for PrEP, but only 18% were prescribed PrEP. And what I really just want to highlight here is the stark differences by age, gender, and race ethnicity. So age, not surprising that the number of people in the 25 to 44 age range were more likely to be prescribed PrEP, likely given access to care and ability to advocate for it. In terms of gender, only 7% of women who are indicated for PrEP were prescribed it. And it was about 5% among Black African American individuals, about 10% for Hispanic individuals versus 40% among whites. So this is something that is a huge problem. And I also want to highlight that these are people who were prescribed PrEP. We don't actually know if they took it. So the numbers are actually probably lower than this. And there are also differences by gender on average length of PrEP use. So it's about 5.5 months for women and 8.5 months for men. So there are a lot of challenges with oral PrEP that we're facing, which is why it is so exciting that we're moving to other formulations that we can offer people. So briefly, just to make sure we're all on the same page, I want to touch base about where we are with long-acting formulations. So long-acting injectable PrEP, or cabotegravir, is administered every 8 weeks in a bi-monthly shot in the buttocks, and there's 1 shot per visit. And studies found that long-acting injectable PrEP was superior to oral PrEP in phase 3 trials. One of these, HPTN-083, was among cisgender men and transgender women, and then 084 was among cisgender women. And I do want to flag that one trial that's currently enrolling, 08301, is examining safety and acceptability of long-acting injectable PrEP for adolescents assigned male at birth. And then another is examining long-acting PrEP among adolescents assigned female at birth. So it is important to think about what this would look like for people under 18. So that science is moving forward, which is important. And these studies found that long-acting versions were safe and well tolerated, and people in non-US sites reported the highest level of preference for long-acting injectable PrEP over oral PrEP. It is not yet approved by the FDA, but hopefully this will happen in the near future. So for long-acting ART, it consists of 2 shots each month. So PrEP is every 2 months, ART is every month, and it is 2 shots. And in phase 3 trials, it was non-inferior to oral ART. And it was approved in January of this year under the name Cabenuva. And so, as many of you know, if somebody wants to switch, as of now, they have to begin taking an oral pill version, the oral lead-in, although that may actually start shifting soon, that they can be able to switch directly. And I want to note that people are eligible only if they are already virally suppressed, and that there's insufficient data on pregnant women as they were not included in the trials. And the Atlas 2M study found that long-acting ART every 8 weeks is non-inferior to every 4 weeks. So that is under review with the FDA, which could have important implications for sustainability if we can move it at least from every month to every 8 weeks. Similar to long-acting injectable PrEP, those in the clinical trials said that long-acting ART was well tolerated and preferred. However, I do want to note that individuals who participate in clinical trials do not always represent people in the real world who would be taking this medication. And in fact, since we started conducting this work with people outside of the trials, we found a much lower level of interest in long-acting injectable ART. And I just want to flag that while I'll be focusing on injectable versions of ART and PrEP, there are also many additional formulations at various stages of development, including rings, patches, long-acting pills, implants, and then longer-acting injectables. So I briefly am going to describe the research that informed this talk before I launch into the case studies. So I conducted this research through the Women's Interagency HIV study, which is now the MaxWise. It combined right at the end of this data collection. We interviewed women in Atlanta, San Francisco, Washington, DC, Chapel Hill, New York City, and Chicago. And we conducted 15 interviews at each site. So 10 with women living with HIV, 5 with women at risk for HIV, except for DC where we did 14 interviews. And participants received $50 plus travel compensation. And the interview questions were open-ended, but we focused primarily on women's attitudes toward long-acting injectable versions of ART and PrEP, how to facilitate its scale-up, beliefs regarding who might most benefit from it, perceived barriers and facilitators, and also focused on women with a history of injection, whether injection drug use or Depo-Provera, to try to understand what that might mean for their interest in long-acting injectable versions of HIV therapy. And then analytically, we used a thematic content approach. So we recorded, transcribed, and uploaded the videos to deduce. And then in using this thematic content approach, there were 3 of us. It was me and 2 master's level students. And we conducted a line-by-line coding of the first 5 interviews to develop a provisional coding scheme. And then we incorporated themes from the existing literature. And then we cross-coded a random sample of 15 additional interviews to finalize the coding dictionary. And then we applied that to all interview transcripts. And we were particularly interested in negative cases of who had different experiences and why that might be. Differences geographically, particularly given some of the broader structural issues that I've mentioned before, and then differences by age. So for example, there are a number of older women that didn't feel at risk at all for HIV, and so would say things like, you know, I don't really want PrEP regardless, it doesn't matter, but I want to talk to my niece about it, for example. So that came up a lot. Also, we pilot tested 15 quantitative questions to explore attitudes toward long-acting ART and PrEP, and I'll loop back to this at the end because these are now being administered in MaxWise, and I'm using them as part of the ART34. So I'm going to give a brief overview of what we found from these papers, but then actually use the case studies to illustrate how what we found may play out in the ground. So in terms of the main perceived barriers, it was a fear of new products. A lot of the women said they wanted their friends to test them first and to hear how they went versus simply a provider saying they were okay. They were afraid of side effects, not just the injection site pain. You know, a lot of people were saying, you know, who really wants bruises everywhere, but also side effects from the medication themselves. Medical mistrust and skepticism came up a lot, particularly this idea that you can't get the drug out of your body once it's injected, whereas for a pill, you can stop taking it. Also, given histories of forced sterilization, that was an issue that came up a lot. Also, transportation and getting to the clinic monthly was something that women discussed, questions about how these long-acting injectables might interact with pregnancy. And then a lot of women just said they already took a lot of pills. So, you know, they would love to get rid of it. But if you're taking 11 and then switch to 10, it's not worth it if it also means going into the clinic every month. In contrast, a lot of women talked about how they believed shots were more effective than pills, that they went into your bloodstream more quickly, that they worked a lot more effectively. They really liked the ease and convenience of not having to carry your own pills, forgetting them if you're traveling. They really liked the idea of increased autonomy and empowerment and feeling like they were more in control of their own care. And also confidentiality. They kept talking about their friends as nosy and all these things we've heard before of going into their medical cabinets, and they just wanted to be able to go to the doctor's office, say they were going for their diabetes or something else, and then not have to worry about it. And I wanted to highlight these because many of these barriers that exist for long-acting injectable versions also exist for oral versions. So while this certainly expands the menu of options and is incredibly important, it's not going to eliminate all barriers. And so I just want to briefly reiterate that while the continued development of these biomedical technologies is incredibly important and exciting, there's a lot more that we have to do in order to actually help us move forward in the HIV epidemic. So I'm now going to turn to presenting hypothetical case studies to help illustrate potential challenges to the scale up of long-acting ART and PrEP. And some of these challenges are also applicable to oral formulations of these medications, but others are unique to injectable modalities. And I'm taking this approach to illustrate how barriers can be unique for each person and how we need to tailor our approaches accordingly. So I developed these hypothetical case studies based on my mixed methods and interdisciplinary research that I've been doing over the past 10 to 15 years. And so while the specific individuals that I'm going to talk about don't exist, they're grounded in the communities and individuals that I've come to know. So in addition to drawing on the interviews from the WIHS study, I also pull from ethnographic work I did with adolescents living with HIV in Baltimore, interviews with HIV providers in the Adolescent Trials Network, so across the United States, and ethnographic research with Black MSM in New York City focused on oral PrEP. So the first case I'm going to present is a transgender woman living in rural North Carolina, which of note is not a Medicaid expansion state. She's white, has a long-term partner who's HIV negative, works at a coffee shop, and does not own a car. In addition, her viral load is not suppressed. So I'm going to walk you through a hypothetical set of interactions that she has with her provider to illustrate some of the barriers and facilitators that came up. So the first barrier, which I'm not explicitly flagging here, is the assumption that providers will know about long-acting injectable ART. And I think for a lot of us, it seems relatively self-explanatory, but we are in university settings where this is talked about a lot more. So we first need to make sure that all providers who see patients living with HIV are aware of long-acting injectable ART, its benefits and barriers, and that they feel comfortable discussing it. We also need to think about how patients will come to learn about long-acting injectable ART. Will it be from a provider, a friend, a television commercial, a health department campaign? And we need to think about what those messages are and make sure that they're streamlined, aligned, and comprehensive. And so once a patient is interested, they need to have an undetectable viral load to get access to long-acting ART as currently approved. So in this instance, the provider mentions long-acting injectable ART and the woman is interested but is not virally suppressed. So the clinic then can work with the patient to identify what specific barriers they're facing. So for her, it may be side effects or stigma or pill burden to help them become virally suppressed. So I want to highlight the Latitude study, which many of you have heard about, that started in 2018 and will run through 2025. And it's comparing the use of long-acting injectable and oral ART for people who are not virally suppressed at baseline. So in this study, patients who are not virally suppressed come in for 6 visits over 20 weeks to receive ongoing social support and financial incentives to facilitate viral suppression. Then at week 24, if suppressed, they're randomized to either long-acting ART or oral ART. So this will be interesting to see how this plays out and what this might mean for getting people who are not already virally suppressed onto long-acting injectable modalities. So in this instance, she gets the additional support she needs and becomes virally suppressed, but is unsure about whether to switch to long-acting injectable ART. However, her provider pushes for long-acting ART because of her challenges with daily pills and saying that he, doesn't trust her to take pills. And I'm actually pulling this example from my ethnographic work with adolescents in Baltimore, where a provider described putting a young woman on Depo-Provera birth control because she already had 3 kids and he just, quote, did not trust her to take her own pills. So we know that long-acting injectable ART is effective if somebody gets it. And we also want to ensure that they can choose the option they want without fear of coercion. So one option to address this potential tension is to use a patient decision aid. And these tools are used to support patient autonomy and to help ensure that the patient can work with the provider to choose the option that best fits their needs and most aligns with their values. Patient decision aids provide clear information about options, are tailored to the specific patient, and incorporate patients' values and preferences. And this is what I'll be developing in the R34 that I'll mention briefly at the end. So based on the qualitative interviews that I conducted in WISE, we developed this R34 with colleagues at the University of Miami to develop a patient decision aid to help women with HIV choose between oral and long-acting ART. And decision aids have been developed for myriad choices, and one very similar to what we propose to do is this one for birth control called Hello Beautiful that was developed by Dr. Christine Dellendorf at UCSF, who's part of the R34. So I wanted to flag what she's done since it's an amazing tool. So one of the major challenges for long-acting ART will be patients shifting from coming into the clinic as little as every 4 to 6 months, especially if they're virally suppressed, to coming in monthly. And for people such as this woman who lives in a rural area and doesn't have a car, that may pose quite a challenge. So we have to think about how to feasibly deliver long-acting ART to places where the patient already goes, which for her may be the clinic where she receives gender-affirming care, or a pharmacy that may be closer to her house. Long-acting ART could be administered as part of reproductive health visits or substance use treatment as relevant. So, given all of these factors and based on her values and preferences, this individual decides to choose to long-acting injectable ART. So for the second case is of a young woman with HIV living in Baltimore. She's married to a partner who's HIV negative, has 4 kids, and works at the airport. Of note, she has a history of injection drug use and is interested in getting pregnant. So I'm now going to walk you through a set of hypothetical interactions that she has with her provider. So one study found that at any given time, 1 in 6 people with HIV in the US is incarcerated. And when they're released, they often leave with only 2 to 3 weeks of HIV medication and no direct link to care. For example, the state of Maine currently has a policy that suspends Medicaid during incarceration, and then there's no outreach or assistance strategies for people who are released. So they're just quite literally released onto the street with no Medicaid, no contact to get re-enrolled. So that's particularly salient for people with HIV or diabetes or chronic conditions that need to be managed. So we need to truly create systems to facilitate reintegration into healthcare for people after they are incarcerated. So for this woman, she comes to the clinic and the provider offers long-acting injectable ART, but she wants to get pregnant and is wary of the side effects. And as I mentioned, she also has a history of injection drug use. And pregnant women were not included in these trials, so we lack data on pregnant women and long-acting injectable ART. So if this woman wants to become pregnant, she should continue on oral ART. She's also skeptical of newly developed drugs, especially after what happened with the Johnson & Johnson COVID vaccine among women in her age group. In addition, she used injection drugs when she was in her late teens and wonders what it would be like to get 2 injections every month and whether that would be triggering for her. So I want to flag that existing research has shown that a high number of women were wary of potential side effects related to long-acting injectable ART and wanted to wait a few years before they would try it to see what would happen among their friends first. In our qualitative data, we found that women with a history of injection drug use had varying responses to long-acting injectable ART. Some felt they should avoid receiving any injections. Some said it would depend on the size of the needle, who was injecting them, and then where in their body, where others said it wouldn't bother them at all. So we need to make sure that providers have discussions in an open and non-judgmental way about which modality is right in that current moment, with the acknowledgement that this will require ongoing conversations as circumstances shift over time. So for example, she may say no now, but over time as her friends use it or she decides she no longer wants to get pregnant, it may change. So similar to the barrier in the first case study of the provider not mentioning long-acting ART, I want to turn to another potential clinic-level barrier. Much of the research focused on long-acting ART and PrEP scale-up has been about whether people will want it, but we also need to examine how these injections will get to clinics, who will administer them, and how they'll be stocked, including potential need for cold chain storage. So this example is for a vaccine, but the idea is similar for long-acting ART and PrEP. So we really need to ensure that clinics are prepared for it. And this is particularly salient because what we need to do for each clinic is going to vary, particularly as long-acting injectable ART and PrEP move out of university clinics and into smaller community-based settings and to primary care providers. There also need to be clear guidelines about where it will be available and who will do the actual injections. So is it a provider in the clinic? Is it a pharmacist? And we have to think about where people will pick it up. So in some university settings, there's a pharmacy on site, so they could, the pharmacy could give it straight to the clinic, but in other instances, somebody may need to go to the pharmacy, take that to the clinic, and then somebody at the clinic would inject them. So that means that there are multiple steps for somebody that they would have to do each month. And we also have to think about stocking. So are people ordering a bunch of long-acting injectable syringes at the same time, or are they ordering them as an as-needed basis? And it will depend on the clinic, but there are a lot of things that we have to think about. And I know people are starting to do really interesting implementation science research around this, which is great. So according to ViiV Pharmaceuticals, the monthly injection cost for long-acting ART will be nearly $4,000, and we don't yet know how much of it will be covered by private insurance or Medicaid. In addition, even if the medication's covered, the associated medical visits may require a copay. And it's quite different for somebody who goes to the doctor once every 4 to 6 months, so say 2 to 3 copays a year, to have to switch to every month and potentially 12 copays a year. So we need to ensure that long-acting ART is distributed in a way that doesn't require copays. So whether there's a different category of office visit, if there's simply like a walk-in, things they sign in and check off, but we need to think about what that means logistically to make sure we're not making this substantially more expensive. Also, people need to be able to get to the clinic for monthly visits. And so well-resourced clinics may be able to initially provide some transportation vouchers, but long-term, we need to make sure we get long-acting injectable ART and PrEP to where people are in the community. And that may mean pharmacies, although usually the vaccines that they give are in the arm, whereas this is intramuscular and in the buttocks. So that's going to take some readjustments to make sure that that's possible, or mobile vans. And so as we've seen, using mobile vans has been successful in other sectors. So for example, providing COVID vaccines to migrant farm workers and factory workers, and outreach around, say, naloxone and clean needles. So we have these models from other ways of approaching public health challenges. So given all of these factors at play and based on the barriers, this woman decides that she's not going to switch to long-acting formulations and she's going to stay on oral ART. So before we move to the final case, I want to briefly reiterate the barriers that arose in this case study and how they occurred across multiple levels, including structural, so the lack of healthcare and insurance continuity, post-criminal justice engagement, the stalking challenges at the clinical level, and then individually, how her fertility intentions and history of injection drug use played out in the way that she thought about long-acting injectable ART. So the third case is a Latino man in San Francisco who identifies as gay and is HIV negative. He's single, doesn't have any kids, and works part-time at a local NGO while he's in school. However, because he's part-time, he has insurance through the exchange, which has a really high deductible. So in 2019, the US Preventive Services Task Force stated that research is needed to develop and validate tools for identifying people at high risk of HIV acquisition who'd benefit from PrEP. So there are significant limitations to existing HIV risk prediction tools because they require that the provider knows the patient's at risk. And so oftentimes someone could go to the clinic and the provider doesn't offer PrEP for whatever reason, right? Because the provider is oftentimes making these calls on the fly based on a lot of potentially biased, or I shouldn't even say potentially, a lot of biased assumptions about who somebody is, who they're sleeping with, what risks they might take. So there was a study that Julia Marcus led that created electronic health records-based models to identify potential PrEP candidates. And they tested this on over 3.5 million members of Kaiser Permanente in Northern California, actually, and found that their models outperformed similar models. So what I want you to take away from this, because I know there's a lot going on in this figure, is look at the purple line at the top. So that is the full model that she created. And the reason that that model outperformed others is because it incorporated things like neighborhood deprivation, substance use disorders, and psychiatric diagnoses, whereas the other models of need for PrEP either looked at who people were having sex with, history of STIs, or treatment, but they didn't include these broader structural pieces. So this type of automated HIV risk prediction tool could help identify potential PrEP candidates, and and those candidates could then use a decision support tool to work with their provider to see if PrEP, whether oral or long-acting, might be useful for them. And in this case study, the provider applies this tool to his patient's electronic health records. And so this man is flagged, and on his next visit, the provider talks to him about PrEP. So this discussion happens, and the provider offers PrEP, but then the patient has a low perceived risk of HIV and decides he might not want it. So I want to flag this because we often talk about populations as being at risk as if they're static and people's lives don't change. However, risk is a dynamic concept that ebbs and flows both in the moment and across the life course, which is why, as you know, we've started talking about, on-demand PrEP and things like that. So to help facilitate its success, I argue that we should approach long-acting injectable PrEP from a patient-centered care perspective, which really requires us to think about the fact that disease prevention may not be the most important health outcome to patients. So we need to think broadly about how we create these messages around long-acting PrEP and oral PrEP in order to help people's ability to choose and also speak to reasons why they may want to incorporate PrEP into their lives. And I understand that given those of you who are here, this is a little bit of preaching to the choir, but I think especially making sure we continue to work with providers to help them think more carefully about how we talk to patients about PrEP. So instead of focusing primarily on HIV risk or narratives grounded in paternalism, this would include thinking about what factors are most important to a given individual around HIV risk. So this may be the ability to have the type of sex that they want with the person they want when they want, and to have the sex be pleasurable and without fear and anxiety. So when oral PrEP first came out, there was this wave of stigma around how it could facilitate condom-free sex. So remember the whole Truvada whore controversy. Now, interestingly enough, some of the narratives have shifted substantially, and people frequently advertise their PrEP use on dating sites. So for some, PrEP use has been a marker of who is worthy of dating or having sex with. However, this means that people who lack access to PrEP for whatever reason, whether they can't afford it, their provider doesn't offer it, can feel like their choice of sexual partners is limited because they lack an access to a certain form of social capital, which in this instance is PrEP. So it's interesting to see the way that PrEP as this sort of commodified entity has shifted over the years. And I also think from a reproductive justice lens, perhaps we could think about framing PrEP as a way to combat stigma. So for example, some people may think that a person whose partner is living with HIV maybe shouldn't get pregnant or it's too risky of something to do, but the availability of PrEP may help shift some of those stigma and norms. So then this individual says, okay, yes, I'd like to try long-acting PrEP because of the discretion, but he's afraid his insurance won't cover it. And I think it's particularly important to work with advocates and policymakers to ensure that long-acting injectable PrEP, once approved, obviously, is covered by insurance in the way that oral PrEP now is. And equally importantly, we have to ensure that all related medical visits and lab visits are covered. So while oral PrEP is covered by Medicaid, as we know, not all states have expanded Medicaid, and the majority of these non-expansion states are in the South, which is also where HIV infections are the highest. So this means there are these people that fall in this gap where they are not eligible for Medicaid, but might need PrEP and the coverage. Also, as you can see in the image here, while PrEP itself is covered, if you're below a certain percent of the poverty level and do not have insurance, the lab tests and clinic visits are on a sliding scale. And this could become expensive if you're coming into the clinic every 2 months for PrEP, like we discussed with the office copay. So in this case study, the man finds out that he's eligible for subsidized medical visits and so decides to take long-acting injectable versions of PrEP. All right, so fast forward 12 months, and after a year on long-acting PrEP, he's decided he doesn't want to stay on it anymore. So he works with his provider to make plans to shift to oral PrEP. There we go. So injectable cabotegravir for PrEP has a really long half-life and also has a long pharmacokinetic tail, meaning that a detectable level of the drug remains in the body for months after the injection. So this figure, and I'll talk you through it, shows the amount of time of long-acting injectable PrEP in participants' plasma based on their time since last injection. So obviously there's a range, but what I really want to highlight is how long it exists at a potentially subclinical level. So if you look at the x-axis, it's time since last injection in weeks. So we're still seeing some of these subclinical levels, a year, 2 years, 3 years out. And while research is still being done to determine the exact clinical implications of this tail, these small amounts of the drug may not be enough to protect against HIV infection. As I'm sure some of you are researching, this means that if somebody goes off long-acting injectable PrEP and is exposed to HIV while the drug is still in their system at a subclinical level, they may develop drug-resistant HIV. And the current belief is that people who stop long-acting injectable versions of PrEP will have to take oral PrEP to cover this tail. It's the same with long-acting ART. You'll have to take oral meds to cover the tail. So people who miss or stop long-acting injectable versions will therefore need to have a stock of oral meds to serve as a bridge until the time they can get back on long-acting PrEP or wean off of oral PrEP. So this is a complicated concept to explain, particularly given our US sort of 15-minute medical visits, and to understand. And so we really need to make sure that all providers know how to clearly communicate this to patients before they decide whether or not they want a long-acting injectable formulation. And this is especially true since it may play out in ways that we can't anticipate and that impact people's willingness to start a medication. So in this instance, in the end, this individual decides that while he started long-acting PrEP, liked it for a year, in the end, he decided he didn't want it anymore and so switched to oral PrEP. All right, so I'm now going to shift to discuss some next steps and then some concluding thoughts. So as I mentioned, the qualitative interviews that I just talked through in this presentation informed an NIMH-funded R34, which I started a few months ago. And so this R34 is focused on developing a shared decision support tool to facilitate women's choice between oral and long-acting injectable ART. And the reason it's focused on women is partially because they do face very unique challenges to HIV medication and support and have historically been underrepresented in clinical trials. And so I wanted to really try to understand what their needs are. though hopefully in subsequent studies, we will expand this to men. And those 15 pilot survey questions that I mentioned on long-acting ART and PrEP are currently being administered to all women in the MaxWise. So it's about 1,500 women with HIV and about 800 who are HIV negative. And so those data finished being collected in September. And they're also longitudinally linked. So we'll be able to look at predictors from, say, 4 or 5 years ago, what that means for interest in long-acting injectable versions of ART and PrEP. I'm currently conducting interviews with 45 medical and social service providers who treat women with HIV to better understand who they think is a good fit for long-acting PrEP and what potential tensions there may be between what the women want and what providers want and how to negotiate that to try and avoid issues of medical paternalism. And then we'll use these data to develop a patient decision aid. And we'll pilot that decision aid with 180 women in Miami, Florida. So as you can see, I'll have a lot of data coming in out of this, both from the interviews and from the surveys with about 2,000 women. So if people have suggestions based on their own work of things I should definitely look at and explore, or working on similar questions, definitely reach out, and I'd love to brainstorm potential collaborations. So in sum, I hope these case studies have demonstrated the need to provide long-acting ART and PrEP in ways that are accessible and that truly allow people to choose between oral and long-acting injectable versions of medications, or neither, as the case may be. However, I know we're living within a limited system. We don't have universal health care. The people that are most vulnerable to HIV are also those most likely to face structural barriers to employment, education, and housing. So we must first acknowledge these structural constraints while rolling out long-acting ART and PrEP, and simultaneously fight to change them. Otherwise, and looping back to the discussion of the fundamental causes theory, it will be incredibly challenging to roll out long-acting injectable forms of ART and PrEP in a way where more than a select few come to benefit. We must also ensure that the tools and technologies we develop, for example, patient decision aids, are relevant for all individuals and do not contain embedded biases that could exacerbate stigma or medical mistrust. The case studies that I shared illustrated lots of potential barriers, but also potential solutions at the structural level. So thinking about transportation and insurance coverage, the community level, distributing long-acting ART and PrEP through pharmacies and mobile vans, the clinic level, ensuring drugs are stocked and decision tools are implemented, and at the individual level, making sure patients understand their choices and are able to decide what they want. I want to wrap up by highlighting a few main threads from the research I've done so far on ART and PrEP. So for those of you who get the reference from this photo, I see you. It's from Field of Dreams, and I'm referencing the phrase, "If you build it, they will come." And I'm showing this to try and push back against the idea that we can frame HIV medication and clinical services based on the assumption that people will come to us and that their ability to access services is purely their responsibility. As I've noted, just over half the people in the US are virally suppressed, and only 18% of those who were indicated for PrEP have been prescribed it. So our current system is insufficient. We need to think broadly about access and incorporate options like mobile vans, telemedicine, pharmacies, non-HIV primary care providers, and even pop-up clinics in places like churches and libraries. And as I mentioned in the second case study, we have existing models that we can build off of, for example, using mobile vans to provide harm reduction services, such as naloxone and clean needles, and to distribute COVID vaccines to factory workers and migrant farm workers. We also need to co-locate care and create one-stop shops for individuals, such as pairing long-acting ART and PrEP with substance use treatment, gender-affirming care, and reproductive health care. I'm not saying this is easy or straightforward, but I argue that we have an ethical imperative to reach all people who can benefit from long-acting injectable ART and PrEP. So in addition to the multi-level barriers to long-acting ART and PrEP, awareness, access, and maintenance, that all came up in these studies, I want to wrap up by highlighting the cross-cutting themes that I referenced at the beginning. And we need to think carefully about public health messaging and how to frame long-acting ART and PrEP as one more addition to an existing menu of options. And I think that's important, not just to draw people in and make people feel supported about who they are and the sex that we're having, but also as a reminder for public health people that we simply cannot use biomedical tools as a way to get our way out of this, right? Getting drugs into bodies is not enough. There's a lot of other things going on that we have to remember. And taking this more inclusive approach will hopefully help us increase confidence in science and to mitigate biomedical skepticism. And we also need to limit the risk of coercion. So providers should not make unilateral decisions about who should be offered long-acting ART or PrEP, particularly in ways that may force patients into choices they do not want, particularly since that dynamic of a patient ending up on a regimen that doesn't fit with their lives, but that is pushed by their provider, will only serve to perpetuate narratives about non-adherent patients, when in reality, they were not able to choose the option that would best work for them. So we need to create systems that facilitate shared patient-provider decision-making so that people are truly able to choose which modality best fits in their lives. We've seen these dynamics play out in other settings, including injectables for mental health treatment and substance use treatment. For example, people who exit the criminal justice system and are being pushed to take naltrexone, which, as many of you know, is a treatment for opioid use disorder, which has had deadly consequences because they have it for a month, do not have access to care otherwise for opioid use disorder, and many have overdosed. So this has played out in other settings in really terrible ways. And I also want to note that these tensions and the risk for coercion become increasingly salient as additional long-acting formulations are tested, so monthly patches, pills, and implants. In closing, I want to note that long-acting ART and PrEP have incredible potential. I am not disputing that, but also that potential will not be equitably distributed without a careful and thoughtful scale-up that addresses substantial constraints across all levels, individual, clinical, and structural. And I want to end by returning to the example of COVID and how the cross-cutting themes woven throughout this presentation are equally relevant to that context. The challenges we face with HIV, for example, stigma, clinical capacity, and equitable medication distribution, exist for many diseases. While the structure of research and funding streams sometimes makes it feel to us like these diseases exist in a silo, we obviously know this is not the case. And as HIV researchers, we need to work with colleagues across disciplines and diseases to create solutions that will facilitate the equitable and just rollout of biomedical HIV technologies in ways that will reach all individuals and ensure they benefit equally. And I also argue this is an important time for us to be able to recenter and create a successful model, since the choices we make as we scale up long-acting ART and PrEP can inform how people respond to other diseases and to future epidemics. So I want to thank a bunch of people, more than I could list here. Lisa Metch, who was the PI of the WIHS study that I worked on, Maria Alcaide and Kerrigan in Miami, who I'm working on the R34 with, and Elizabeth, who helped with a lot of the interviews, to all the WISE co-authors as well, particularly the women who took the time to speak with us and the WISE sites that participated, and to the funders as well. And thanks to all of you for coming and listening, especially since I know how we're all just up to here with everything Zoom related. So thank you again.
Thank you so much, Morgan. Fantastic talk. And so you hit on a lot of big kind of existential questions about, like the framing of advances in biomedical science with kind of all the justice kind of dimensions that we need to attend to. So yeah, so just eye-opening as always when I hear you talk. So with that, we have hopefully a good amount of time here, 10 minutes for some question and discussion. To get started, there's a couple questions here for the top about long-acting ART available in Africa, if you have any insights on that. And then some of the side effects that you were finding in your studies from participants, if you could speak to that.
Sure. So I think I appreciate the point about scaling up long-acting injectable ART in Africa, particularly because I think it's so problematic, and this is another discussion, that the clinical trials occur in settings that are the slowest and the last to actually get access to the tools that they are developing. And to be honest, I have not heard at all when it is going to be made available. And I think that in and of itself is a huge problem. Similar in Latin America. I have some colleagues that work particularly in Peru, and they're just starting to discuss it, but I think it's not at the top of people's minds because with COVID especially, there's so much going on. I don't mean that as an excuse. I'm just saying that is what people are offering. But yeah, so I wish I had an answer, but it's not something that I've heard is happening anytime soon. And even in the US, it's just starting to be offered in places. I was talking to colleagues at the University of Miami, and they're not even offering it yet because they don't know how it's going to work. They don't know what pharmacies will get. They don't know where they're going to give it to. And then the second question, sorry, you said was Africa. Oh, and the side effects.
Side effects, yeah. So I think Paria listed some, I guess, known side effects, but I don't know if there was any from your data that perceived or not make a difference there.
Yeah, no, that's really helpful. And thank you, Paria, for listing those out. So those are the main issues that came up. It was interesting. The women focused, it was less actually on how much it would hurt, because a number of them were like, you know what, I've gotten antibiotic shots before, like in the buttocks, it's fine. It was a lot of the physical dimensions. Like they kept saying, they're like, the quote that sticks in my head is, bruising is not a cute look. And I think we have to think about that. If someone's coming in every month, it is going to, you know, they may feel odd and the bruising may last for 3, 4, 5 days to then try to go and have sex and be like, why do you have these giant bruises, right? Like, what does that mean? If you're trying to be discreet, that obviously makes it quite hard to be discreet. Are there going to be assumptions about what medications you're taking? So I think even though that might not be a side effect that we think of the side effect around what it means for, oh, it is painful for that person, we don't actually think about what kind of forced disclosure it might require to a partner. So those were the kind of issues that came up. And just the idea that you can't take the drug out of your body. Like we say, you know, they're like, the scientists say it's fine, but is it really? What is it going to mean for me? What if I'm that 1%? So it tended to be sort of broad versus the specific headaches or nausea.
Yeah, great. So questions, you can unmute and go ahead and ask, or if you want to raise your hand, can call on you. Yeah, we have a question here. I think you're on mute.
Gotcha.
Sorry, but thank you for those responses. Yeah, it was really interesting to me that we have advanced so much with HIV treatment. And I'm hoping and keeping my fingers crossed that this treatment will get to Africa soon, especially sub-Saharan Africa, where the rates of HIV prevalence and incidence are up the roof. I feel like we could really use this kind of intervention for treatment. But my follow-up question was just to understand a little bit more about the eligibility. Why is it only people who have viral suppression are eligible for the injection?
Yeah, that's a really good question. So I think there are a couple of reasons. I think there are probably people on the call who can speak to this more about why the decision was made at the clinical trial phase. But my understanding was because they wanted to make sure, so they started with the oral lead-in. So they wanted to make sure that people who were taking that specific medication did not have any side effects and that that medication would work for them and could get them to being virally suppressed. And then at that point, they could transition them over. And I think that is my understanding. Someone else, if somebody else knows, feel free to unmute yourself and speak specifically to why that decision was made at the clinical trial level.
Yeah, I know. I don't want to put anybody on the spot.
I can respond. Sorry, this is Padia. Yeah, so Morgan, you said it just perfectly, and also to prevent future drug resistance. And I think it was just being very conservative. So there's a lot of clinics now that do direct to injection when doing the oral lead-in, or getting people to undetectable is not a possibility. So like a lot of clinics in San Francisco are even doing direct to injection. So that's probably likely to change in the future, but for the time being, that's what's recommended, to just be very conservative because they're so new.
Thank you.
Yeah, and I can definitely say that, you know, with the long-acting injectable implementation science study that a lot of people here are working on, that Cat Christopoulos leads, at least the last few patients in that we've been discussing have done direct to inject. So it seems like that's in theory versus in practice kind of a gap, as you mentioned. So interesting how that plays out. Other questions?
It will play out differently across places where I think providers are more comfortable. So university settings, that will probably be more feasible. But what I asked about that with the provider in Miami, and she's like, oh, no, we won't do that. We'll follow the guidelines. I was like, okay. So that'll be, the implementation piece will be really interesting to see.
Yeah, and you brought up some great points between the kind of those university clinics versus other private clinics that are offering HIV care, and I can imagine those models are going to look quite different. Yeah. Other questions here? I can follow up. Well, Morgan, if you don't mind too, I found this, you know, based on the work that we're doing here in San Francisco. I want to say that the mistrust component isn't as prevalent versus, I know you've worked in Baltimore, and other places, and specifically with the Black community. Can you give some insights into what that's looked like? Because I imagine that's going to be a pretty big driver as well.
Yeah, thank you for bringing that up. So these interviews, we did conduct them at UCSF, but that came up a lot more in the Atlanta and the North Carolina and the DC sites. And I think this narrative, and it was an interesting tension because I think some of the women, it was a slightly higher among women who did not have HIV. And I think that's because the women with HIV had been so looped into care over time that the sort of generalized medical mistrust that they would speak to was mitigated by their close relationship with their own provider. And so I think they were a little bit of a unique situation. But I think that is going to be something that is going to be particularly salient for PrEP, because a lot of people are not going to have, those long-term relationships, or they're going to go to a provider that they might not know as well and, talk about HIV risk, and someone will be like, oh, you should try this. And they're like, wait, I don't know you. You're now telling me to inject this thing into my body. Like, how do you expect? Or I'm going to go to a pharmacist that I've never met and I have to quite literally bend over and take my pants off and someone's going to inject. They're just all these things where it's like, we have to be so careful about how this plays out. I do think it will be different for people living with HIV because they do have that connection already to the clinic. Obviously, when someone's newly diagnosed, it may be different and take time to build that trust. But I think particularly on the PrEP side, we'll have to think carefully about the challenges of medical mistrust, particularly since you're giving someone a pill for a disease or an injection for a disease that they don't have, that they may not even think they're at risk for.
Right. Thank you for that. And so with that, we're at the minute before, so right on time. Thank you, everybody, for joining us today. Thank you again, Morgan, for an outstanding talk. And so I hope you have a rest of your good Tuesday.
Great. Thank you,
everybody,
for coming.
Bye, Morgan.